Hi, my name is Dr. Megan Winter. I work at Winthrop University Hospital in the Division of Surgical Oncology. I am a board-certified general complex surgical oncologist with special interest in cancers of the skin and soft tissue, but also of the gastrointestinal tract, including esophagus, gastric cancer, and colon and rectal cancer. Skin cancer is one of the most common cancers affecting adults in the United States. In fact, it's increasing at an alarming rate in young people. Skin cancer is a cancer that arises from the cells that make up the layers of the skin. And some of the subtypes, which you may be familiar of, are basal cell carcinoma, which is the most common skin cancer and affects more than 1 million people in the US in a year. Squamous cell carcinoma, which affects several 100,000 people a year. And then much more rare but much more aggressive is melanoma, which is a skin cancer that comes from the pigmented cells in our skin. How do we get skin cancer? All 3 types of skin cancer I've listed, basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, are all very closely linked to our exposure to ultraviolet light, the main source of which is the sun. So sun exposure over the course of our lifetime, as it accumulates, is the primary risk factor for skin cancer. For basal cell and squamous cell, it seems that the accumulation of sun damage over time is most important. For melanoma, it seems that shorter periods of intense sun exposure, for instance, sunburns when one was a child, or exposure to sun tanning beds, are more important for melanoma. But in all cases, the amount of sun exposure that you get increases your risk of skin cancer as you age. I'll talk first about squamous cell carcinoma and basal cell, and then melanoma. Basal cell and squamous cell carcinomas tend to be on the sun-exposed areas of our body, on our cheeks, on our ears, on the forehead, and on the neck, the shoulders, areas that have been repeatedly exposed to sun throughout our lifetime. They appear as first scaly or pearly nodules on our skin. They may itch, they may break through the skin, or what we call ulceration. And these can be excised either in the office or if they become large in the operating room. And typically that is all that is required for treatment of basal cell and squamous cell carcinomas. The risk of spread of these tumors beyond the skin is very rare, although every single patient that I treat, I do a full body skin examination and an assessment of the lymph nodes, and we talk about their particular risk factors for skin cancer and what we have to look for in the future. Melanoma tends to spread in a slightly different way. Melanoma spreads to lymph nodes when it's quite small. Melanoma has the ability to spread in other areas of the body. And so depending on the stage of melanoma that we diagnose, we may have to do other procedures in addition to a surgery for the melanoma, which might include looking at some of the lymph nodes that the melanoma might drain to, and that may change depending on the site of the melanoma in the body. A lot of people are nervous when they get diagnosed with a skin cancer because the most frequent site of skin cancer is on the face. Naturally a very sensitive area in terms of preserving your cosmetic appearance, the face that you greet people with every day. Dermatologists, there are certain dermatologists who do a special procedure called the Mohs procedure, where a skin cancer, particularly in a sensitive area like the face, is removed with a very small microscopic margin of tissue. But there are some that are too big or are not appropriate for Mohs surgery that end up in my office. And I try to reassure people as much as I can. I've treated skin cancers from the top of the head to the bottom of the foot. And one of the most important people that I collaborate with is our team of plastic surgeons who come to Winthrop Hospital. I work closely with them, and whether I have to have them cover a wound that I create from a removal of a skin cancer with a skin graft or with a local flap, they're with me and with the patient every step of the way, and can meet several times before an operation for adequate planning to make sure that not only do we do a good cancer operation, but we do one that preserves the cosmetic and functional appearance of the face, which is so important. Some people wonder whether there are alternatives to surgery for skin cancer. And for basal cell and squamous cell carcinoma, particularly if the surgery to undertake removing them might be large, or if the patient is not in a situation or a shape to undergo surgery, there are actually alternatives. Our radiation oncology department has a lot of experience treating squamous cell carcinomas and basal cell carcinomas with a particular type of radiation. The investment of time is obviously more than with a surgical excision, but it is possible to get a very good response, and it is very well tolerated. And likewise, for basal cell carcinomas that are unresectable at the moment because of their location, their size, or again because of patient preference or the condition that a patient is in, there are newer agents on the market now that are showing very promising results in the treatment of basal cell carcinoma. The most important thing to me is that I think about a treatment protocol and the sequencing of a treatment protocol for each patient that is tailored to the particular patient, to the particular type of skin cancer that they have, to the location where it is, to the effect that I would have doing the surgery or not. And that together with my radiation oncologist, my medical oncologist, my radiologists, my plastic surgeons, we come up with a plan that's best for that patient. We have a weekly multidisciplinary tumor board in which I have an opportunity to present individuals I've seen, to show pictures, to show imaging if it's appropriate, and to come up with a number of different opinions that I can then bring back to the patient. So every person who comes to Winthrop has the benefit of all of those specialties, thinking about their particular case in order that we really exhaust all treatment possibilities for each person. Just after I'm asked by a patient, what do we have to do to treat this? One of the next questions that usually comes up is will this come back? Is there a chance that this can recur? And for skin cancers and for melanoma, the answer is yes, it can recur. The very fact of having had a skin cancer shows us that that patient has a risk for developing new ones and need to have a very close relationship with me and with a dermatologist for skin checks about every couple months for the first couple years after the diagnosis and treatment of a skin cancer, and then for sure annually thereafter. So having a good relationship with a dermatologist is important to me, and if a patient comes to me with a skin cancer who doesn't have a relationship with a dermatologist, we make sure that we establish that as they're getting care. For skin cancers that can metastasize, like melanoma, depending on the stage, there may be imaging studies that we get to establish that there's been no metastatic disease, but that patient follows with me very frequently thereafter to monitor for signs or symptoms of recurrence, which are important to identify early. So every patient who comes with a diagnosis of skin cancer becomes my patient for the rest of their life and will need to be seen very closely by a dermatologist for sure, because this particular skin cancer that we treat may not come back, but there may be others. There are also individuals who are at particular risk for aggressive and aggressively recurrent skin cancers, and those include individuals who are immunosuppressed for reasons of another cancer like a lymphoma, who are getting chemotherapy for a condition, who have HIV, or who have been radiated in a particular area. Those individuals, it's important for me to help them understand that the skin cancers that come up, we have to be on top of them and we have to treat them very quickly because they can grow very fast and yet are curable if we can catch them early. Another question that I get asked is, what are the risk factors for skin cancer, and does it run in families? The risk factors for skin cancer are that one has fair skin, one has skin that freckles. Generally, that's associated with a fair complexion, blue eyes, and being of European ancestry. Though I will mention that skin cancer affects people of all ethnicities and all skin colors. And if you are a darker skin color, it doesn't mean that you are immune to skin cancer. Having been sunburned, having had a lot of exposure to the sun, is a risk factor for skin cancer. Being immunosuppressed, either by taking medications for a transplant or being on chemotherapy or having a blood disorder that makes you immunosuppressed, that is a risk factor for skin cancer. Having had another skin cancer, another area of your body, is a risk factor for developing a new one. And then there are rare familial relationships between for melanoma that runs in families. These families tend to have a number of moles on their body that look atypical, that look concerning. And so certainly if you have a family history of melanoma or of other cancers, bring this to the attention of your dermatologist or to me, because we can recognize some patterns that might lead us to be concerned for a familial syndrome, mostly with melanoma and less so for the other skin cancers. A lot of people wonder when they should seek the advice of a dermatologist or visit someone like myself in the office. And a very commonly cited rule is the ABCDE rule for melanoma. The A is for asymmetry. Melanomas more than benign moles tend to be asymmetric in their appearance. They're darker on one side and lighter on the other. The border of a melanoma can be more irregular than a benign mole, more jagged and less respecting of a smooth line. The C is for color. Melanomas can be of various colors. They can range from having no color at all to being very dark to being even red appearing. D is for diameter. Any moles greater than generally 6 millimeters in size, which is about the size of a pencil eraser, ought to be evaluated by someone with experience evaluating for skin cancers. And E is for evolution, meaning has it changed over time? Benign moles can change over time, but that is more characteristic of a skin cancer. Certainly anything that is growing, anything that is painful, anything that has broken through the skin, is bleeding, ulcerated, or itching, all of those things justify coming to see a dermatologist or myself. For anyone diagnosed with a skin cancer, they've already probably heard from their dermatologist and from their primary care physician, and they've probably seen it on the internet, how to protect yourself against skin cancer, the first one or the second one. And there are some wonderful resources available from skincancer.org and other melanoma-specific sites on the internet. But there are some basic rules that are easy to follow, and they all have to do with minimizing your exposure to ultraviolet light. Wear sunscreen when you are outside, and the sunscreen should be at least SPF 30. There is no data to suggest that going above 50 is any better than having a good strength sunscreen. Make sure that it is a broad spectrum sunscreen. It has to be effective against both UVA and UVB. Most sunscreen on the market today satisfy that criteria. Which leads to my next thing: make sure your sunscreen is new and not the bottle that you've had in your bathroom for a couple of years. The amount that you put on is important. There are two ways that sunscreens work. One is that they are meant to absorb the rays of sunlight in order that they not penetrate the skin, and the other is that they're meant to reflect the rays of sunlight so that they don't penetrate the skin and damage the skin. The reflective ones tend to be the ones that are whiter. Both need an adequate amount of application in order to be effective, and they need to be reapplied after a couple hours. So after you go swimming, after you towel off, after you've been out for about 2 hours, you must reapply. And in order to apply enough, the general rule is 1 ounce, which is a shot glass for your whole body. Avoid sun in the hottest times of the days, and that's between the hours of 10 a.m. and 4 p.m. Seek shade, create it for yourself. Wear a hat, wear clothing, wear sunglasses. And avoid at all costs tanning beds. Tanning beds have been classified by the World Health Organization as a carcinogen on the same level as smoking is for lung cancer. There are a couple questions that people ask me very frequently. They ask whether sunscreen and makeup is adequate. Based on what I've told you about the amount of sunscreen that you have to apply, if you have an SPF 15 powder that you apply lightly, that is not adequate. Something is better than nothing, but I can't tell you that that's adequate. And the other question people ask me is whether UV light given in the setting of curing manicures is dangerous. And the answer to that is that the current information that we have now is that any amount of UV light adds to the damage that we accumulate in our skin. The amount of UV light that's used during the curing of gel manicures is minimal. However, given what we know about the damage that UV light can accumulate, the best recommendation I can make is that you put on sunscreen on your hands about half an hour before you go to the manicurist if you are going to go. And that may be effective, although that we don't have a lot of information for me to give you an answer one way or another.